Hello, and thanks for joining me. I am Bobby Hardesty, and this is my presentation on the management of cytomegalovirus in the oncology population, CMV Showdown, tackling the mega menace in oncology and hematopoietic stem cell transplant. Here are our learning objectives. I'm not going to go through them in detail right now, but they're here for your review. Cytomegalovirus, or CMV, otherwise known as HHV5, is a herpes virus that is common among U.S. adults. About 50% of people have been exposed to CMV at some point and are therefore CMV seropositive, but it does not typically cause issues unless you're immunocompromised. Like other herpes viruses, CMV can lie dormant in the body. CMV specifically can lie dormant in just about any tissue or organ system, and it can be reactivated by states of immunosuppression such as hematopoietic stem cell transplant, or HSCT, certain moderate to high risk anti-cancer regimens, and solid organ transplant. I'm not going to be going over solid organ transplant in depth in this presentation because we just don't see many patients up here in the northern region for solid organ transplant, but just know that CMV is still an issue in SOT. Active CMV disease can manifest itself as many syndromes such as pneumonitis, hepatitis, or colitis. For HSCT patients, the most important CMV risk factor to assess is CMV serostatus. Recipient positive serostatus is the highest risk specifically because the recipient has virus lying dormant in their body. Then after transplant, the newly grafted immune system is weakened by intensive immunosuppression and has no defense against CMV reactivation, especially if the stem cell donor was seronegative and had no prior CMV T-cell immunity developed. Other risk factors apply to all patients, not just HSCT patients, These other risk factors include the use of lymphocyte depleting therapy, graft versus host disease, as this requires intensive immunosuppression for treatment, including the use of high-dose steroids. So just keep that in the back of your mind when assessing infection risk in our other patients that are also on high-dose steroids as well. And lastly, the use of other moderate to high-risk anti-cancer agents. Other moderate to high-risk anti-cancer agents include alemtuzumab, PI3K inhibitors, bispecific antibodies, and brentuximab, among others. In addition to these, there's other drugs that NCCN has listed for increasing CMV risk, but the ones you see on the screen here are the drugs that CMV monitoring may be considered in per NCCN. Other lymphocyte depleting agents that can increase risk of CMV reactivation include proteasome inhibitors, purine analogs, high-dose steroids again, as well as therapeutics typically only used in solid organ transplant like thymo and calcineurin inhibitors. Not to say that we'll never see these agents, because we may see them in our aplastic anemia patients as well as other indications in the oncology population. Prophylaxis versus preemption is an important point to understand in the grand scheme of CMV management. Prophylaxis with letermovir is only indicated in CMV seropositive allogeneic stem cell transplant patients. For everyone else determined to be moderate to high risk for CMV reactivation, we can manage them with the preemptive strategy, which includes close CMV monitoring with weekly CMV QNAT tests, or quantitative nucleic acid tests. Then if CMV viremia is detected, we treat. We'll touch on this again a little bit later because it can be confusing. I wanted to introduce a quick patient case just to drive home some key points. So TN is a 54-year-old male with AML in relapse. He is post-allogeneic HSCT. So TN is the recipient. He is CMV seronegative, and his stem cell donor was CMV seropositive. So it's a donor-positive, recipient-negative transplant. You're looking through TN's chart, and you notice that he's not receiving any antivirals for CMV prophylaxis, but rather we're monitoring him weekly with the preemptive strategy. Do you think that this is appropriate treatment at this time for TN? Feel free to pause the video. Otherwise, yes, this is appropriate treatment for TN at this time. This was a donor-positive, recipient-negative transplant, which means it's intermediate risk. And again, per NCCN, only high-risk recipient, CMV seropositive HSCT, require prophylaxis. Alemtuzumab is a lymphocyte depleting agent. While alemtuzumab is not routinely used in current practice, I still wanted to go over it because alemtuzumab is a potent lymphocyte depleting agent. So it's a good example of when lymphocytes, especially T cells, are depleted, CMV reactivation risk skyrockets. Alemtuzumab has multiple indications and has been found to cause CMV reactivation in 2/3 of patients. CMV diagnosis can be tricky because CMV diagnosis in SCT patients or stem cell transplant patients is different than that in other populations. In HSCT patients, any level of CMV viremia, even low-level viremia, is considered CMV infection, and we treat them as such. This is not the case in other populations, such as solid organ transplant or patients with solid tumors receiving high-risk anti-cancer agents. We'll talk about this again later on because it can get a little murky. Back to our patient case now. If we remember, TN was being managed with the preemptive strategy, and now, 2 months post-transplant, TN has a positive CMV quant test of 1,400 copies per milliliter. He has no symptoms of any CMV syndromes. What do you think we should do at this point? Treat or continue preemptive observation? If you said treat, you would be correct. In HSCT patients, any level of CMV viremia would be considered infected regardless of symptom burden. So if they have viremia, we treat. Here are our recommended CMV treatment options. Our first 5, ganciclovir, valganciclovir, foscarnet, cidofovir, and maribavir, are all used as treatment options for CMV, where letermovir is only indicated in prophylaxis. But before we dive into all these options in depth, I wanted to outline these NCCN recommendations that I'm basing a lot of this presentation on. Starting on the left side here, NCCN breaks up high-risk patients into 2 groups, allogeneic stem cell transplants and anyone receiving alemtuzumab. Now moving up here to the prophylaxis portion, we see primary prophylaxis with letermovir is only indicated in allo-HSCT seropositive recipients, and everyone else can be managed with the preemptive strategy of close CMV monitoring with weekly CMV quants. And if viremia is detected, then we treat with one of the agents that I'm about to talk about. Ganciclovir is IV only. It's phosphorylated by viral kinase UL97 into its active form to inhibit viral DNA polymerase. Its adverse effects include hematologic toxicities such as neutropenia. Valganciclovir is the oral prodrug form of ganciclovir. Its mechanism and side effects are the same as ganciclovir, but its dosing is a little bit different. Additionally, oral valganciclovir has been found to be non-inferior for treatment of CMV as compared to ganciclovir. Foscarnet is second-line therapy, usually reserved for patients that have failed GAN or valganciclovir. Mechanism is a little bit different. It's a non-competitive inhibitor of viral DNA polymerase, and it does not require viral kinases for activation, which is important, and we'll get to that a little later on. The main adverse effect of foscarnet is nephrotoxicity, and administration requires aggressive IV fluids to decrease the renal toxicity risk. Each dose needs IV fluids, which makes administration of foscarnet a little bit inconvenient, especially for patients that have a hard time tolerating IV fluids. This is a study on foscarnet versus ganciclovir for CMV treatment in SCT patients. The primary endpoint was occurrence of CMV disease or death at 180 days post-transplant. Results showed that treatment outcomes were not significantly different between the foscarnet and ganciclovir groups, and either option would be appropriate for CMV treatment. However, the nephrotoxicity risk associated with foscarnet, as well as the need for pre-treatment IV fluids, makes ganciclovir a more desirable treatment option due to both ease of administration, not having to worry about fluid overload, and additionally, foscarnet is the more expensive option. So that's another reason why ganciclovir might be preferred. This is a graph from the study showing event-free survival over time. The dotted line represents foscarnet, solid line represents ganciclovir, and if you're having a hard time distinguishing between the two, that's the point, I think, because the study showed that there was no significant difference between the two groups. Cidofovir has a mechanism similar to that of ganciclovir, but it does not require the same viral kinases for activation. Cidofovir is our third-line option due to its unfavorable toxicity profile. You can think of it as having the toxicities of the previous two agents added together. So not only do we need to worry about myelosuppression, but we also need to worry about nephrotoxicity. Additionally, cidofovir must be administered with probenecid 3 hours prior to each dose, as well as 2 and 8 hours after, plus aggressive IV fluids to prevent accumulation in the kidney and associated renal toxicity. Maribavir is our newest and least studied drug that has an FDA indication for CMV treatment. It has a novel mechanism that inhibits the phosphorylation of proteins necessary for viral replication. It is very well tolerated as its adverse effect profile includes only mild GI complaints. The Aurora trial you see on the bottom of the screen here was a comparative non-inferiority trial between maribavir and Valgan that showed maribavir was inferior to Valgan for CMV viremia clearance at 8 weeks. This is the reason why maribavir is considered fourth line for refractory infection. But of note, there was less treatment discontinuations in the maribavir group due to the favorable adverse effect profile. Lastly, letermovir, which only is indicated for prophylaxis in HSCT seropositive recipients, is a viral DNA terminase inhibitor, which is required for DNA processing and packaging. It can be given IV or PO, and it's very well tolerated. And I liked this little cartoon here that I got from the manufacturer website showing where letermovir, or Privimus, acts on the DNA viral terminase complex to prevent proper assembly of viral structures. All these agents we've gone over are on our formulary here at UC Health with no restrictions, with the exception of maribavir and cidofovir. Both of them are still on formulary, but they do have restricted use criteria. For cidofovir, the use criteria is currently in development, so I'm unable to share that. But the use criteria for maribavir is listed here below the table, and for time's sake, I won't go over it right now. This table represents the average price of an 8-week treatment course for a 70-kilogram patient per drugs.com pricing estimates. Duration of therapy is going to drive the price more than anything because CMV viremia clearance typically takes anywhere from 2 to 8 weeks, depending on the patient. So these pricing estimates are meant to be among the most expensive we should see, hopefully, given the long 8-week duration. There are a few different clinically significant resistance mutations I wanted to touch on. First, up here we have the UL97 gene that encodes for the kinase responsible for activation of GAN and valganciclovir. So mutations in this kinase can lead to resistance against those agents. Next, we have this UL54 gene, which codes for the viral DNA polymerase. If we remember, the polymerase is our main drug target for GAN, Valgan, foscarnet, and cidofovir. So mutations in this UL54 gene can lead to multi-drug resistant virus. And then lastly, we have the UL56 gene here that can cause alterations in the proteins that make up the DNA terminase complex and lead to letermovir resistance. This is a table format of the resistance mutations I just explained. Also, I wanted to define resistance. It is when we've been treating a patient with appropriate therapy for at least 2 weeks and their viral load is not improving or even worsening. If this is the case, we'll want to order a CMV genotyping test in order to detect those gene mutations if they are suspected. This down here is a screenshot of that genotyping test from the UC Health lab website. It is a send-out lab to ARUP in Salt Lake City, Utah, so the turnaround time will likely be at least a week, if not more. But here is that test number down here for your reference if you ever need to order it. Okay, back to our patient case now that we've gone over all of those drugs. So if we remember, we decided to treat TN. So we started him on valganciclovir, but then 2 weeks after therapy, his viral load has increased from 1,400 to 2,600. We obtained a CMV genotypic test that showed a UL97 mutation. So at this point, what is the most appropriate treatment option for TN? Maribavir, letermovir, high-dose valacyclovir, or foscarnet? If you said foscarnet, you would be correct. Foscarnet does not require UL97 for activation and has similar efficacy to Valgan. It is, however, a less desirable option due to its inconvenience of administration as well as higher cost. There are other CMV treatment options out there, such as high-dose valacyclovir, which has been used for CMV prophylaxis in the past, as it was seen to be more effective than acyclovir for CMV prophylaxis. But overall, neither of these agents have great activity against CMV, which is why they are no longer recommended by NCCN for CMV prophylaxis. We just have better options. CMV IVIG is also an option, but it's only currently indicated in solid organ transplant and is reserved for last line of therapy because it's very expensive. Additionally, leflunomide can be used off-label for adjunctive treatment of CMV, and brincidofovir, which is a lipid conjugate prodrug of cidofovir, is under investigation for use in CMV treatment because it has a much more favorable safety profile than cidofovir, but it is not currently commercially available in the United States. For the sake of time, I won't go over the monitoring parameters here, but it is here for your reference. I did want to wrap up these guideline recommendations for CMV management now that we've discussed all the drugs. So again, prophylaxis with letermovir is indicated only in CMV seropositive allogeneic hematopoietic stem cell transplant recipients. Other HSCT patients can be managed with the preemptive strategy, where we monitor weekly CMV viral loads. And if we detect viremia, then we treat. For non-HSCT patients, these would be our solid organ transplants or high-risk cancer agents in solid tumors. We would treat them a little bit differently. We can still manage them with preemptive therapy, but any detection of low-level viremia may not directly correlate to treatment. In primary literature, a viremia threshold of 1,000 to 4,000 has been studied and used to indicate the need for treatment, but unfortunately there are no clear guideline recommendations for viral load threshold to initiate treatment in this population, and you may see variability from institution to institution on viremia thresholds for treatment. All right, now to make sure everyone's paying attention out there, a couple of questions for you. True or false, patients with B-cell chronic lymphocytic leukemia being treated with alemtuzumab require universal CMV prophylaxis with ganciclovir? If you said false, you're correct. Per NCCN, alemtuzumab patients can be managed with the preemptive strategy. And again, I'm beating this point like a dead horse at this point, but CMV seropositive allogeneic stem cell transplant patients are the only population that receive empiric prophylaxis with letermovir. Next, what CMV antiviral requires aggressive pre- and post-hydration plus probenecid with each administration to prevent nephrotoxicity? You got it. It's C, cidofovir. Cidofovir requires probenecid at 3 hours prior plus 2 and 8 hours after the dose plus aggressive IV fluids to prevent nephrotoxicity. Few populations we have yet to touch on in depth for CMV management, which are patients with solid tumors and patients receiving immune checkpoint inhibitors. Thought this would be a great time to include this screenshot from one of my favorite movies, The Breakfast Club. Don't you forget about these populations. CMV in solid tumors is not as well studied as in other populations, such as HSCT and hematologic cancers. There has been a few retrospective studies completed on this population showing that CMV infection could still be a concern in solid tumors. The big takeaway from them is this bolded bullet point at the bottom here showing 50% of solid tumor patients with CMV viremia will go on to develop clinically significant CMV disease. CMV may be underreported in solid tumor patients because screening is not routinely done. Additionally, when CMV viral load testing is done, viremia thresholds for treatment are not well defined, as we previously talked about. So in conclusion, for patients with solid tumors, early detection and treatment for CMV could prevent unnecessary antibiotic exposure as well as prolonged hospitalizations. Now for a quick point on CMV in patients on immune checkpoint inhibitors, or ICIs. This 2022 study here compared the incidence of CMV in cancer patients with and without ICI therapy. And they found that CMV was more common in those without ICI therapy than with it, which makes sense when you think about it mechanistically, because ICIs tend to bolster the immune system rather than suppressing it. But the rates were not zero in the patients treated with ICI, rather it was nearly 8%, which means that it could possibly still be a concern in these patients. Also, CMV syndromes can mimic the symptoms of ICI-induced immune-related adverse events, or IRAEs, such as colitis. So just because a patient is on an ICI does not mean that their colitis is necessarily an IRAE. Other infectious causes, such as CMV, need to be investigated. Additionally, patients on ICIs may require treatment of IRAEs with high-dose steroids, which we covered earlier. We know high-dose steroids increases a patient's risk for CMV reactivation. So just don't forget about CMV in this population. So what about HSV, or herpes simplex virus? I've been told that this clinical question has come up quite a bit on whether or not patients on CMV antivirals need additional HSV prophylaxis. There is a great statement about this from NCCN. So in patients receiving CMV treatment or prophylaxis with ganciclovir, valganciclovir, foscarnet, or cidofovir, additional prophylaxis with acyclovir is not necessary, given that these agents are active against HSV. However, it is required in patients receiving letermovir because letermovir does not have activity against HSV. So what's next on the horizon for CMV treatment? There are more studies being done on maribavir and letermovir to investigate its place in therapy. And we have other drugs in the pipeline, such as brincidofovir, which I had previously mentioned, as well as some other drugs. And what's really amazing about this is that if I was doing this presentation just 5 or so years ago, this slide on future directions would only be focusing on maribavir and letermovir because these are our newest options. So the fact that we have so many new drugs in the pipeline is really exciting. I won't read through all these conclusion points, But if I can leave you with anything, it would be that prophylaxis versus preemption and understanding patient-specific risk factors for CMV is really important when trying to figure out who needs prophylaxis, who needs treatment, who doesn't need anything, who can we manage preemptively, all encompassing for managing CMV in the oncology and HSCT population. That will do it for my presentation today. Here are my references. Thank you for listening, and I hope you learned something.